this is a concerted effort for substance abuse here on campus, as well as throughout our community. And a lot of this is spearheaded by the Prescription Drug Working Group, as well as some funding through the DIDAR program. And so I want to make note of a couple of things. One is today's Grand Rounds that will be followed up with a movie this evening, Oxyana, which is sponsored by Bucks funding, and that will be a great movie. For those of you who have not seen it, it's really an interesting movie looking at substance abuse in rural Appalachia, specifically in one small town in West Virginia. It will captivate your attention, I promise. And then also we'll have an event next Thursday from 10 to 2 on campus, where we have an opportunity for staff, faculty, students to return medications that are old, expired, and unused. So please take part in all of that. And for my introductions, introducing Dr. Sarah Melton. She is on faculty at the College of Pharmacy here at ETSU. She has a long history in substance abuse and activism, and it's my pleasure to introduce her this afternoon.
Thanks, Jeff. I'm going to make this very short because I want our students to go ahead and start talking, because some of them have to get to class and one has to actually get to an exam. So Generation RX is a program that started with the Ohio State College of Pharmacy, and now is done in collaboration with the American Pharmacists Association, and then different pharmacy schools across the country have student organizations that have taken on Generation RX for the prescription drug abuse education and outreach programs. A couple of years ago, we wanted to be innovative and start our own toolkit that could be used out in the communities to educate healthcare students and providers about appropriate prescribing of controlled substances. And so under the leadership of Abby Searle, she put together the provider toolkit, and that's what you're going to see today. It starts with a scenario of a patient that is prescribed medication for a pain symptom, and you can see what can easily happen when we don't work together interprofessionally. And really the goal of this presentation is to talk about the important parts that pharmacists have, physicians have, any prescribers, public health, nursing, all of us coming together to make sure that we try to prevent prescription drug abuse through appropriate prescribing. So I'm going to let the students introduce themselves and go ahead and hit with the program. It's about 50 minutes long, and we'll have time at the end for questions. Take it away, guys. Start and introduce yourself real quick.
Certainly. My name is Ron Carrico. I'm a student with the Gannett College of Pharmacy, and also with this very building, the College of Public Health. I'm ETSU's first pharmacy doctorate, Master's of Public Health dual degree candidate. I beat out my cohort by about 2 weeks, so I get to say it's kind of like being the older twin. I also have the distinct pleasure of being the president this year of the Association of Interprofessional Healthcare Students, which is a student group on campus that is dedicated to facilitating interprofessional experiences and education for all healthcare professions.
My name is Rebecca Ralston. I'm a third-year medical student at the Quillen College of Medicine.
I'm Jeremy Wilder, fourth-year medical student at Quillen College of Medicine.
My name is Abby Searles. I'm a final year student pharmacist.
My name is Brandy LeBlanc, and I originally hail to represent the College of Nursing. I have my bachelor's in nursing. I'm a student pharmacist in my third year, and I am also a master's of public health candidate in epidemiology, and I am the committee chair this year for Generation RX.
All right, so we're going to go ahead and get started because, like Dr. Melton said, one of us has to get to an exam. So we're actually going to start off with a video case study. Now, whenever you came in, there were paper case studies back there. You can pick one up and read through it. It has a couple questions on it. But the video is really just a repeat of the actual paper case study. We wanted to sort of bring it to life and make it a little bit more entertaining. So we're going to watch that. While we watch it, we are talking about prescription drug abuse today. So I want you to try and pick out the things that you see that went wrong in this case, who messed up where, what could we do differently, just sort of analyze that as we watch. Sorry guys.
Scroll down on the sidebar, hit X.
There we go.
Play in full screen.
Hi, I'm Jessica Smith. I have an appointment this morning. What's your date of birth? 10/24/68.
Right in here, Ms. Smith. We'll be here with you in just a few minutes. Good morning, Mrs. Smith. How are you?
Okay.
What brings you to see us here this morning?
Oh, I've got this really bad pain in my neck. I had a car accident last week and the guy rear-ended me, and ever since then my neck has just really hurt.
Okay, well, I'm sorry you feel so bad. Let me go ahead and get your vital signs. I'm Brandy, I'm your nurse. I'm going to be assisting the doctor today.
All right.
So let me get your blood pressure, get some vital signs, and then, have you tell me a little bit more about what's happening. Did you go to the ER? Did they tell you anything to take or do for it?
No, I couldn't go to the ER. I just thought I'd just take some Motrin, see how it did, and I've just gotten worse.
Have you ever taken anything stronger than an ibuprofen or a Tylenol for pain, or had these kind of problems before?
No, I don't think so.
Okay. Well, I will pass this on to the doctor, and he'll come in and he'll talk to you, and we'll see what we can do to make you feel better.
Thanks.
Hey, Ms. Smith, how you doing today?
Okay.
Good to meet you.
Hey.
Hey, so it says that you're having some pain in your neck.
Yeah, I had an accident. A guy rear-ended me last week out down there on the main road, and I don't know what happened, but I didn't go to the ER or anything, but now it's really hurting. I can't really move it very well.
All right, any pain in your arms?
No.
No. You can feel me touching you here?
Yes.
Good. Okay, where is it hurting your neck?
Right back here, right there.
Right here?
Oh, yeah.
Sorry about that. All right. Well, I would give you some Percocet to help with the pain and some medicine. Have you ever taken that before?
No, never.
Okay. And you don't have any allergies to any medicines, doesn't look like?
Sulfa.
Sulfa. Okay. All right. Good. So we'll just give you 90 of the Percocet. Okay. You can take one or two. Kind of depends on what you eat. And 3-4 times a day if necessary. And then if you need more, just give me a call.
Okay.
Okay. I'll tell you what. I need to get onto something else. I'll have the prescriptions. She'll be in just a second.
Okay.
Okay. Good. Good to meet you.
Thanks.
Okay.
Ms. Smith?
Yeah.
This is what the doctor has prescribed for you. Hopefully it'll help you make you feel better. Just take it to the pharmacy, and we'll see you when we see you.
Okay.
Hi, how can I help you?
I need to get a prescription for Percocet for my neck.
Okay, it'll be just a few minutes, but I'll get it ready for you as soon as I can.
Thank you. Hey. Right. Bye-bye.
For Smith? Okay, we've got it ready for you. Would you like to speak to the pharmacist? Okay, well, I hope you have a good day.
Thank you.
We're just gonna keep going for the sake of time.
Good morning. Danger zone. A powerful tornado barrels through Billings, Montana, tearing apart businesses and ripping the roof off an arena. This morning, the damage is well into the billions. Like sand through the hourglass. So are the days of our lives.
Mom, here are a few pain pills for your ankle. I think they'll help you as much as they help me relax. I'll see you tonight, Jessica. Jessica Smith. I'm a patient there. I need to make an appointment to get my pain pills renewed. You don't have an appointment for 3 weeks? Well, what am I going to do? I've only got about 3 or 4 of my pills left. Okay, thanks. Hello, yes, this is Jessica Smith. My husband goes to see Dr. Jones there, and I need to make an appointment for me to come in.
While that's playing just credits, we'll go ahead and talk about this for a minute. So this video is obviously an exaggeration. We don't expect that to happen with every patient. But you guys help me out. What did you see that was an issue here? What went wrong in this case? Anybody?
She wasn't offered an NSAID right off the bat. Right off the bat, it was narcotic, and it was 90 of them, and I think that's entirely too much.
Absolutely, that's excellent. What else?
The doctor never discussed the expectations of the pain medicine.
Very good. What else?
The pharmacist and counsel.
Yes, the pharmacist and counsel. You guys are hitting exactly on these points. Anything else?
Do X-ray, a neck injury, if they've never been together.
Yeah, so the patient assessment was pretty minimal. Anybody else?
The patient left medications for her husband.
Yeah, so she was sharing the medicine with somebody else and just left it out on the counter, right? We don't know if she has kids or animals that can get up on the counter, somebody who might walk by and pick up those pills and think, hey, this looks like candy. Yeah, very good.
I say no screening for substance abuse
That's
or
right.
alternate therapy, like
Yes.
physical therapy.
Mm-hmm. Absolutely. So there were obviously a lot of issues in this case. So what we want to do today is we're going to give you a little bit of background on what prescription drug abuse is, why this is an issue in our area, and then we want to talk about what we can do as healthcare providers, no matter what profession we are in, to help prevent this happening in our patients, to make sure that these issues that we pointed out just now and that we've seen in this case don't happen every single time that we see a patient. So to get us started, Brandy is going to give us a little bit of background about what prescription drug abuse is.
Thank you, Abby. So in order to do this, we have to talk about some of the definitions about it. So what is prescription drug abuse? It's defined as the intentional use of a medication in a way other than medically described. In the case study, you saw the example where she gave it to her husband who had never had a physical exam, hadn't been screened if it was inappropriate. Also, this is stimulated to give you a feeling of euphoria or to get high. So, is prescription drug abuse really a big problem? Why are we here? Why are we talking about it? Why have we developed this multi-collaborative case study? Well, 6.1 million, or 2.4% of people aged 12 and older use prescriptions illicitly, or as though they were street drugs. This is very disturbing. We have a high influx of prescription drugs going into our patients nowadays. Most of them have multiple comorbidities, and they're not taking them appropriately. And with these type of medications, especially things like opioids and benzodiazepines, this is really problematic because they have dire consequences when taken incorrectly. So, let's talk about where do we get them. So, everybody hears it's from the drug dealer up the street. What's really happening is they're getting them from friends and family. So Jessica Smith shared them with her husband. Kids are getting them out of their grandparents' medicines cabinets. Friends are sharing them with friends because somebody goes, oh, hey, I rolled my ankle. And they're like, oh, well, I've got some Percocet or some Loratab. Here, you should take this. It'll help you. Or people are just going into other people's homes and stealing them. We're not getting them from drug dealers anymore. People are actually getting them legitimately. Now, an important thing is that most people think that it's a multi-provider problem. Only 1.9% of people are getting them from doctor shopping. is kind of the slang term that we use to refer to it. So that's a very important piece. These are one prescriber type people that didn't set out to become addicts, but ended up due to a lack from multiple healthcare providers not getting the education and the instruction they needed to not end up in this type of scenario. So the last alarming statistic that I have for you guys is that 2.8% of youth age 12 to 17 currently use prescription medications non-medically. So this is things like pill parties. This is just stealing it out of mom and dad's medicine cabinets. This is having it freely available. Or maybe their parents give it to them because they're a teenager and they think that they can handle the same medications that an adult would. So addiction. We need to define this if we're going to talk about prescription drug abuse. It's a big problem. It is a primary chronic disease. Let me emphasize chronic disease. This is not a choice. This is one of the stigmas that we're battling, is that people are not recognizing this as a disease. This is a chronic disease. If you're an addict, you will always be an addict. You may be in recovery, but this is a disease you will fight for the rest of your life once you go down this pathway. Much as somebody who has COPD, a lung disease, will have to fight this for the rest of their life to try and maintain optimal function. It affects 40 million Americans. This is greater than heart disease or cancer, which you hear lots of national initiatives for. 96.5% of addicts begin using substances before they were 21. What does that tell us? That tells us that it is our children that are misusing medications because they are unaware of the dangers before they're 21, and by the time they get into their 20s, get into their college ages, they're already addicted. They're already suffering from this chronic disease as young adults. So, in addition to addiction, we must talk about tolerance. It occurs when a drug is used repeatedly over time. We see this with lots of medication. Diabetes medications over time will no longer work because the body becomes immune to them. It's a biological response in which the receptors are less receptive or less available to the original dose, and therefore you either must escalate the dose or change the medication to achieve the same effect that you had previously. Often tolerance to certain symptoms happens before others. So if somebody's taking an opioid for pain, their tolerance to the effects of eliminating their pain develops much more quickly than their tolerance to things like constipation or respiratory depression, which are other side effects of taking this medication. So discussing these side effects with your patients is a very serious thing, and it's a job of not just the pharmacist, but we should be doing it very well since it is mandated, nursing, medicine, and there should be other initiatives out there that really focus on this. So everybody's saying we're going to talk about neurobiology over lunch. To understand how addiction works, we must first look at the brain. And here, you see that we have to talk about dopamine. Any drug that is going to cause an addictive personality or cause you to be addicted must go through the dopamine pathway. If dopamine is not released, it is not considered to be addictive. So we start here, and you see the substantia nigra, which is right here. From there, it is stimulated up to the nucleus accumbens where dopamine is released, which then will cause dopamine to be released into the striatum and the hippocampus and the frontal cortex. What we gather from that and what we know is that as dopamine is released, we get the rewarding sensations. We get euphoria, we get pleasure, we get compulsive behavior. So in the absence of dopamine, once this pathway has been developed and it changes with drugs, people will compulsively do things to find these drugs or continue to do it to feel this way again. Excuse me. It also affects our decision making. Now we can't talk about dopamine without also talking about serotonin. Dopamine and serotonin work in conjunction in the brain. So as you change your dopamine pathway, you will also simultaneously change your serotonin pathways and change the effectiveness of serotonin on your brain. Because as you can see, they project into the same areas because there are different hormones with different functions. So when you're dealing with serotonin release in the brain, you deal with mood disorders, you deal with memory processing, you deal with sleep, and you deal with cognition. So changing your dopamine pathway will simultaneously change the way that serotonin affects these same areas in your brain. So that was a lot of information to digest. So let's bring it back to addiction. In the ventral tegmental area, we see that opioids, benzodiazepines, and amphetamines work directly there. From there, we know that opioids and benzodiazepines sensitize the dopamine receptors, which means that they're more prone to respond in a higher fashion than they were previously. So they are sensitizers, whereas amphetamines actually cause an increase in the dopamine release. Amphetamines will also hit the nucleus accumbens and cause dopamine release there. So now you have drugs that are starting here in the ventral tegmental area and projecting forward into the nucleus accumbens, sensitizing them to normal levels of dopamine and potentially increasing dopamine. So these are alarming facts on how addiction gets started and why it's so hard to combat, because we now have potentially more sensitive receptors and we have multiple mechanisms in which you can become addicted. And with that, I'm going to turn it over to Rebecca to talk to you about the second part.
So now that we've covered some of the basics of prescription drug abuse and addiction, we'll discuss what we can do to help prevent this epidemic. Originally adapted from the infectious disease model, we have the universal precautions of prescribing, which aim to monitor, to prevent and monitor the abuse and misuse of prescription drugs. Just like with infectious disease, these are implemented with the intention of every healthcare professional intervening with these precautions. So it's the job of every member of the healthcare team to ensure that these steps are taken in order that we can improve patient outcomes and begin to stop this epidemic. So with the first step of the precautions, we are aiming to obtain an accurate diagnosis. And this is the step, this is going back to the basics. We should be doing this all along the way with every patient. But even though it's so basic, a lot of times we overlook this when prescribing pain medications. We all know that interviewing the patient and the family is essential in obtaining an accurate diagnosis. And interprofessional communication is also key because a lot of times patients will tell different healthcare professionals different things. The second step in the universal precautions is to try the less risky interventions first. So multiple interventions should always be tried before we prescribe controlled substances. NSAIDs are a great place to start when you're looking to control pain in patients. And there's also currently quite a bit of research out on meditation and its impact in medical practice and also its impact on quality of life in patients who are struggling with a lot of pain. There's also some support for yoga, acupuncture, and relaxation techniques and their roles in pain management and also things like anxiety. So additionally, atomoxetine, which is a non-stimulant treatment for ADHD, it was shown to have no significant difference in efficacy as compared to an immediate-release methylphenidate in a review of 9 randomized controlled clinical trials. So as you can see, there are many less risky interventions that have proven to be effective, and we encourage you to explore your options before prescribing a controlled substance. When a patient is prescribed a controlled substance, it's our responsibility to educate the patient on the medication. So what should the patient expect to get out of this medication? And when should they expect it to start working? And what are the potential risks of taking this medication? When it comes to controlled substances, we must discuss with patients the potential for abuse and addiction. As you saw in this video, it wasn't discussed with the patient, and it easily caught up to her. So patient education is the responsibility of every healthcare professional involved, and it should occur whether the medication is a controlled substance or not. Having the patient sign a controlled substance agreement is a great way to ensure that the patient is understanding the information that you're providing. Many of the agreements state that a patient cannot see controlled substances from other sources, that they'll take the medication as prescribed, and that they won't share it with family or friends. It can also include the right of the provider to ask the patient to take a urine drug test upon each appointment with a physician. It also often includes goals for the treatment and a limit on the number of refills. This type of agreement it holds the patient and the provider accountable for the medication that's been prescribed. The next step in the precautions is to administer urine drug screens. A lot of times, the use of urine drug screens has a negative connotation. When providers hear the term urine drug screen, they get a little bit leery of the patient and why they're needing that screening. And when patients hear urine drug screen, they become a little bit defensive and hurt that the provider won't trust them with the medications that they've been prescribed. But this can be avoided pretty easily by just explaining to the patient that a urine drug screen is used for every patient encounter. The urine drug screens are used for the benefit of the patient. It's not a way to try to catch the patients and to tell on them. It can be used as a means of patient education. And like any other tool that we use, we need to know how to use urine drug screens properly. Drug screens are often conducted by a nurse before the patient is seen by a physician. When using the urine drug screen, we need to be sure that we understand how to read and interpret the results. And false positives are rare, but they are possible. So keep watch for that. And then also urine drug screen should be used just like any other medical test. So for instance, before we prescribe warfarin, which is a blood thinner, we do an INR, which is a blood test that determines how thin the patient's blood already is. When we prescribe diabetes medications, we do daily glucose checks. in order to make sure that the patient's glucose is staying at the same interval every day that it's supposed to. So why should controlled substances not require a urine drug screen?
All right. Thank you, Rebecca. Of course, again, my name's Ron, and I'm going to talk to you guys a little bit about the risk factors for drug abuse. Part of the reason that I wanted to take this on is because I like risk factors, of course, but we have to be sure that we use them with great care. Public health uses them all the time, so it might be second nature to us, but other clinicians may not know. A patient can have every risk factor and never abuse a drug, or a patient can have no risk factors and still become an abuser, but the presence of every risk factor increases the likelihood. So these are the patients about whom they need to be more cautious. One of the first risk factors that's worth discussing is family history and or genetics. People have done studies with family members and so on to show that roughly 50% of a patient's risk for addiction may come from genes alone. But of course, like a lot of diseases, and we usually ask about these things with family histories and so on, but like with a lot of diseases, it's often not only genetics. Remember, one risk factor alone does not make a disease, typically, we hope. Usually there are also other things that may help precipitate the genes. So we talk also about the patient history in terms of comorbidities. The National Institute on Drug Abuse, or NIDA, estimates that about 6 out of 10 people who become addicted have another psychological comorbidity. It could be anxiety, it could be depression. Those things could be because of the things that Brandy talked about, the differences in neurochemistry that could be common to both addiction and the psychiatric disorder in question, or they could be using the feelings that they get from the drug of choice to help treat the symptoms of the psychiatric disorder. So it's very important to follow up on that. The big one, though, is past behavior has been correlated to increased likelihood of substance misuse. So people who have been addicted to other things, even cigarettes, have the higher likelihood of being addicted to future things that we may expose them to, like opioids. For instance, one predictor of opioid misuse, past cocaine use, was a predictor of opioid misuse in about 68% of patients that we would see and interact with. So what's the way that we find out if a patient has been using things non-medicinally or things in ways they weren't intended? The simplest way is to ask. There's a one-question drug screen, which is something along the lines of how many times in the past year have you used an illicit drug or used a prescription drug for a non-medical use? A study was done with this and showed that it is 100, this is going to be from my public health folks, ready? 100% sensitive and about 73% specific. So everyone that said, yes, I have, did. Everyone that said, yes, I have used a drug non-medicinally did in fact use it. And about 73% of the people that said no had not. So it actually works quite well. Of course, what do you do if somebody says yes? You can follow up with more detailed tools that we can give you guys access to as a part of our comprehensive prescriber toolkit. And like Dr. Gray mentioned, you can also check the prescription drug monitoring database, which is an online tool that's available to clinicians and healthcare professionals in the various states that helps track which patients were prescribed which addictive substances at which times. So, but one of the most important risk factors, and the one that we keep coming back to time and time again, is a lack of knowledge. We always have to ask ourselves, are we educating our patients? We have to make sure that the patients are aware of the risks of treatment, especially if it's something they're going to be on for a long time, that they can define addiction and possibly see it coming, and that they understand the benefits and risks of their controlled substances. Now this last point is goes back to how a lot of people might get started or how a lot of people might acquire the drugs. And this goes for everyone, not just patients who carry a high likelihood of addiction or are going to be using medications for a long period of time. These are universal precautions, so we should tell everybody that has a potentially addictive substance that it should be stored with care and disposed of with care, because we don't want these finding their way into the hands of people who are hurting themselves with them. So, with that, I believe I'm going to turn it over to Jeremy and let him take over for me.
All right, guys. Now we're going to kind of talk about the whole process from the first initial encounter. And when you start talking about prescribing any sort of controlled substance, you need to talk to the patient so that you and they also have an understanding where they want to go. What is the end goal for this treatment? How are they doing now, and where do they, both physically and mentally, and where do they, how do they want to feel? What is their goal? And we've all probably seen these little assessments for pain. I think this is a child's one actually here, it's used for children. But anyway, you need to figure out where they are on that scale and where they want to be. And one of the biggest misconceptions a lot of patients and some providers have is that the goal of this treatment is to get rid of the pain. That's not the goal of the treatment. The pain, and they need to know that. The pain's not going to go away. You just want to make it more tolerable. And documenting that you've discussed that with the patient is very important. Also, like any other sort of medical treatment, it's important to start a short-term trial of any sort of medication. That way you're able to, going back to assessing the function, you're able to see where they're at, and then after treatment, see where they are. And that's very important because you want to know whether you're going to continue the same therapy, modify the therapy, or discontinue the therapy. And that's very important from a physician and pharmacist standpoint, because you need to determine whether increasing a dose of the medication is going to solve the problem, or increasing the frequency that you take it. And that's something that a lot of physicians don't think about when they're prescribing controlled substances for pain. I'm supposed to point that out. Okay, and well, how do we do this? An important point is the second one there. Sometimes a patient isn't able to give a very objective feeling about how they're doing. Sometimes it's important to make a collaborative effort to talk to friends or family. Sometimes they're more objectively able to assess the treatment and how it's going. It's also important because sometimes they're the first that will notice signs of addiction and misuse. The exit strategy. For all professionals, I think sometimes we all don't like to ask help from other people, and we always want to be able to fix things. That's kind of the nature of why we went into these fields. And with that being said, sometimes we are afraid to ask for help. And it's important to always know that you, number one, have a plan if things go south, and number two, you need to know what support you have as a professional, and that will be on the next slide. But if your patient does start showing signs of addiction or abuse, it's important to know that you have different options. Listed are tapering the dose or alternative medications. And tapering the dose is just a fancy phrase for slowly decreasing the amount of medication that the patient is taking. Because with a lot of medication, it's very important not just to quit cold turkey, as you might say. Also, there's many other alternative medications that someone mentioned earlier that are non-controlled substances that you can provide during the tapering period that will help with some of the symptoms that the patient was either initially experiencing or might begin to experience as you start taking them off of the medication. And right here, this is what I was talking about, knowing that you have support as a professional. SAMHSA is a program that's put on by the department, it's led and funded by the Department of Health and Human Services. And essentially it just provides different treatment for people who are struggling from addiction and abuse. And I won't talk much about it, but you can go online and look that up, and it takes you to this website that lists all the local support groups that are available, and it also has, and you can limit them and narrow it down by what insurances, specific ones accept, what type of treatment, whether it's inpatient, outpatient, and that way you can kind of cater to your patient. Periodic reassessment, and this kind of is just repeating what we were talking about with the short-term trial. You just need to continue just follow up with your patient. That's one of the things that was missed on that initial case study that we showed in the video. Patients are dynamic. They aren't going to, just because one of them has not shown signs of abuse or addiction doesn't mean that they don't have the potential. So periodic reassessment is very important, which kind of leads into this slide here. I won't go into them, but the COM, which is current opioid misuse measure, and SOAP tests. These are just assessment plans, and they're short questionnaires that you fill out, and the COM will you use during therapy while the patient's already on a controlled substance, opioids in this case, and determine if they're showing signs of abuse. And then the SOAP is a form that can be filled out prior to initiating therapy that shows the likelihood or potential for abuse in a certain patient. And with that, I'm going to hand it over to Ms. Patty.
All right, so the last of the universal precautions is prescribe conservatively. So to illustrate this point, we're going to use a fun example of food. We all like food, right? And we know that some people in this world can actually get addicted to food, so that's why we're going to use it. So let's say that you haven't eaten all day long. You're starving. You're so hungry. All you have is $1. What are you going to be able to buy with that $1? Maybe a bag of chips? Well, that might hold you over for an hour, maybe, a little bit of time, but it's not going to last you all day, right? What if you had $20? You'd probably be able to go out to a nice dinner with that. You probably have leftovers for tomorrow. You could feed yourself pretty well with $20. Well, what if you had $50? Well, then you could probably take a couple of your friends out to lunch with you, right? So you have plenty to share. So prescribing conservatively sort of goes along with this. If you don't give enough, you're not really treating what your symptom is. But if you give too much, you're providing opportunities for someone to either share or to overindulge themselves. So now to bring that back to medicine and controlled substances, whenever you are conservative with your prescribing, you're preventing someone from taking that medication and selling it to someone, maybe accidentally not taking all of it, leaving it in their medicine cabinet, and then somebody comes over and takes it out of their medicine cabinet. Or you're preventing them taking too much. They think, well, I've got plenty to last me today, I'll just take an extra one. This one made me feel good, so I'll take a couple of extra. If you're being conservative, you're preventing these things. But like I said, with that $1 bag of chips, if you remember that, it's not going to last you. It's not really going to treat your symptom. You have to be careful with being over-conservative. If you're over-conservative whenever we're prescribing controlled substances, you may not be treating the symptoms that they have. They may actually present with a syndrome called pseudo-addiction. Pseudo-addiction is a syndrome in which someone presents and they look like they're an addict. They look like they're searching for drugs. And in reality, they're just in pain or whatever it may be that their controlled substance is treating. They just are not, their symptoms are not relieved. So we have to make sure that we are conservative, but that we're not over-conservative. Now we're going to move on from the universal precautions and talk just a little bit about documentation. I know this is everybody's favorite subject. It's so much fun to document, but it's so important for so many reasons. Documentation allows us to have appropriate and effective communication with others. So it allows for appropriate communication with our patients because we're making sure that we're getting all the information from them. Whether it's screening information, results from tests, any information that we get from them, we put it in documentation. And then when someone comes behind us, whether it's a nurse, a physician, pharmacist, anyone who may read it, they know exactly what's going on with that patient. They make sure that that person who comes along behind you to treat them is treating them with the most knowledge that they can possibly have. And communication is really important because, well, we need communication. We've talked a lot about communication today. I've heard several people mention it. And so why is it so important? Well, with our patients. If we're communicating effectively with our patients, then they know what's going on with their medications. They know what they're doing with these medications. They know what to expect, how to store them. We're making sure that they are part of their treatment. We're not just treating them, that they are part of it too. We communicate with our colleagues. Maybe we have a patient that we don't really know what to do with. Maybe one of our colleagues has more experience with addiction or with prescribing certain controlled substances. Maybe we need to go and talk to them to get some advice. Interprofessional communication. This is one of my personal favorites, but it's so important because if you imagine you have a physician in one office, you have the nurse who's maybe outside the office, and you have a pharmacist that's in a retail pharmacy down the street. If we're not communicating between all of us, you're not effectively treating that patient. Because what if that retail pharmacist has known that patient for years and they see signs of addiction, but they're not communicating with the physician because they don't feel like they have an open communication system or open relationship with that physician? Well, then that physician never knows that this patient is exhibiting signs of addiction. That lack in communication can actually harm our patients. So, fight against prescription drug abuse. That's why we're here today. And we showed you the case study earlier, so I'm going to ask you a couple more questions. After you've heard the universal precautions, what else would you do differently in this case? If you'll remember back to it. You guys talked about several already. So you said NSAIDs, right? We said proper screening and actually doing a real physical exam. What else? Somebody give me something else.
Could check the CSMD.
Yes, exactly. You can check the controlled substance monitoring database. That's a big one, and it's something easy that we can do, especially now in Tennessee. Anybody else? One more, and I'll quit asking questions.
set up an actual follow-up.
Yes. Very good. So it's that short-term trial and then making sure that you're reassessing all the time. Yeah, absolutely. There's so many things that we can do, and they seem like basic, simple things. But if you remember those statistics from the beginning, we're obviously not doing a good job. Something somewhere in the system is not working. And if we go back to the basics, maybe we can help fix some of that. So just to give you a little bit of evidence about why we chose the universal precautions, this is actually a proven system. Project Lazarus was a project that was conducted in one county in North Carolina who had opioid overdose deaths. Their rate was way above the national average. So they started this project, and in 2 years, they decreased opioid overdose deaths by 69%. And they actually only decreased their opioid prescriptions by 1%. So they cut the deaths by half, over half. But they didn't really change their prescribing habits. So what changed? They did a lot of education. They educated their providers and they educated their patients. And that enhanced communication actually saved a lot of lives. So no matter what profession we're in, we all will take an oath. We all came into this profession because we want to help people. We don't want to cause harm. If we aren't putting steps in place to prevent prescription drug abuse, we are indirectly causing harm. So we're here today to challenge you to step up to make a difference in prescription drug abuse. And we think that together we can do it. You can do it. You can make a difference in your practice, and we challenge you to do so. So, does anybody have any questions? Go for it.
So you presented this a good bit to doctors and providers, I don't think.
Mostly, I don't think we've had a group of physicians yet. We've had a group of nurse practitioners and PAs. We've presented it at the College of Medicine and the College of Pharmacy. That's it for now. But we are hoping to expand, and it should eventually be going up on the National Generation RX website. So they have several other toolkits as well, ones for youth. We're looking to get that advanced and put that up there for any college of pharmacy across the nation to be able to use this toolkit.
So what were the nurse practitioners' responses?
They were very grateful. A lot of them didn't realize that there were a lot of non-controlled substances available. Most people don't think of using something like Celebrex or doing a high-dose ibuprofen regimen for a short term. So educating them really on what it is to be, what some of the different things are. And as we mentioned, anamoxetine, which is Strattera, used for ADHD. It's much more prevalent that you hear about the controlled substances versus alternative therapies. If I say alternative therapy to a healthcare provider, most commonly they're going to think of things like herbals and things like that. But that's not necessarily the case. There still are other prescriptions that work equally as well that do not have addictive properties that we should be exploring first. So it's about educating providers about what those are, prescribing providers about what those are. With that, I've pulled up our website. You have this if you picked up one of our brochures. We actually have a Generation RX provider toolkit website, and we have broken it down into different resources for different healthcare providers. And also, if somebody wants to see this presentation presented to their practice or in their setting, that's available, as well as all of our resources to give your own presentation. So just to click through some of them, we don't expect everybody to do all 10 of the universal prescribing precautions at any given time. But if you can adopt, say, 2 to 3, that you're going to do with every single patient that you're considering doing a controlled substance with, you will improve your patient care dramatically, and you will help to decrease the likeliness of drug abuse and addiction. So I just clicked on the nursing one. It shows about the prescription monitoring thing. It hyperlinks to different tools they can use that are readily adaptable for practice that can be put in patient's chart, although a lot of places are going to EMR, but it gives them a starting point for what should this look like? What can I do and how does it work? Same thing for other prescribers such as PAs and actual medical doctors or physicians. It gives you things that hyperlinks to other tools that maybe physicians and prescribers aren't as aware of. So that's why we developed this resource, because we can come and tell you about it, and we don't have the time to come in and give you in-depth, this is how you do this assessment, this is where it is. But we can give you the resources to go and get it and implement it in your practice so that you have safe and effective prescribing habits for controlled substances.
Yes.
So with the prescribing rates, we know they've just gone through the roof over the last 2 decades. And there's some, culture in medicine that has driven that, and patient advocacy and that sort of thing, and just attitude towards pain as a symptom in general. But one of the things that's so striking is the variation in rates between the states. That we see, for instance, like the 10 highest prescribing states for painkillers are all in the South. The 10 highest are all in the South. And Tennessee is, I believe, tied for first. Last data I saw, it's like 1.5 prescription.
This past year, we're 8th, and New Mexico is number 1.
Okay. I wonder, I think it was 2011, maybe, I guess that's a big shift.
For overdose deaths, drug overdose deaths, New Mexico is still New Mexico's number 1, and we are 7th or 8th.
For prescribing rates, though, I wonder if it was like 1.5 prescription. Anyway,
Yeah.
my question is, because you guys are doing such good work, you know, you're getting this idea out, and I know the education is minimal for physicians. And do you guys have any thoughts on why we see such high prescribing rates in areas like Northeast Tennessee? You know, a pill for, or what is it, 50 pills, 50 hydrocodone for every individual or something like that?
It's pretty ridiculous. It's a multifactorial, multicultural issue, typically related to more rural areas, which Northeast Tennessee, Southwest Virginia, and Eastern Kentucky are all notorious for. This past year, we were our second leading cause of death in Tennessee was drug overdose death, which is alarming. In Virginia, it's still number 1, and I think it's 2 or 3 in Kentucky as well. So it's a multicultural. We have taught people that there's a pill for every ill, and then we have prescribers that aren't necessarily aware of things that are going on. So you have prescribers that want to fix their patients, as we talked about. We have a lack of education that's going on. We have a culture that says it's inappropriate to have pain. We've developed that culture through medicine and also through patients as well. So we have to fix a lot of our cultural aspects and societal aspects on pain. A lot of people in this area are blue-collar people, so they need to work. Well, if they're in pain, they can't work. So instead of treating things and using rehabilitative services like physical therapy, because people will go, I don't have time for that. You know, I've got to work, I've got to make money, or I'll lose my house, I'll lose my job, blah, blah, blah. So there's so many facets that we need to correct myths about. That education is probably the best place to start for us, as well as doing things like the prescription monitoring drug program to make sure, trying to decrease the flow as well. So we have to pretty much change the way we're thinking as healthcare providers and change the view of our patients before I personally feel like we're going to see a difference in this. We are seeing some decreases, but it's still, like you said, astronomically high.
And the other thing is, you know, in Florida, where we had predominantly the pill mills in the United States, they really clamped down on it, and so they've moved up to Georgia, and now it's to Tennessee, because Georgia is, and now Tennessee's clamping down, and so we're going to see it continue up through the states until they have, you know, things in place. I think that's another reason. I mean, the number of pain clinics we have in Tennessee is astronomical compared to other areas of the country. So.
Yeah, I think that's everybody's question, I feel like, and I do a lot of research in this area, and I haven't seen an answer, you know, like a definitive answer. And, you know, I'd be interested to know what, like, some way to look at that movement of the pill mills, because that's, you know, that's not your valid prescribing, you know, that's your trying to run as a business, but then we see most people who are abusing are getting it from one doctor, and you know, so it's like, anyway, I think it's really important and hard to measure, hard to get at.
Definitely.
Yeah.
But as far as pulling apart the risk factors, you say you haven't seen any literature that's gone into really detail about quantifying those things?
The risk factors?
You personally, I mean, as far as sociocultural risk factors, things that in the community or in the culture that may contribute.
Oh, no, yeah, no, there's tons of research in that area.
I was just curious.
Just with regard to prescribers and the culture of prescribing and why we see it so different, and it's varying so much between different, you know, where you live matters is what they say. You know. And you know, why people behave a certain way, there's, you know, that's my research interest, but you know, again, why there's so much supply in different areas.
To me, that sounds like a great medicine epidemiology collaborative study right there.
Yeah, agreed. Maybe get your card.
I have one.
Thank you.
Other questions or comments that you guys have in general?
I mean, I know, I heard you say that you were short on time, so I hesitate to ask.
We're good
this.
now.
Okay.
I think, I
Just
don't
for
think
one.
anyone else, yeah.
Can you show me how to use the SAMHSA website to find, say, an AA group in Elizabethton?
So this is much the way a patient would do it. You can tell them, even if you get the acronym wrong, it's probably going to come up on Google or Bing, whatever they're using, because it's cool.
I think if you go back,
You just come over here and do it.
I can't remember completely when I was doing it. If you click there, it'll bring up a thing you put in a, maybe I might have made this up.
Are you making stuff up on there?
I saw a treatment locator button on.
Yeah, where was that? Because that's where,
It was on the homepage. You back up one more time right there.
Yeah.
Yep.
So there's a couple
Oh.
different ways to get it. Used to, you would go and you could just Google it, so you could say.
37643. Yeah.
Okay, that works. And I think that it's probably going to pull mostly Johnson City ones over, because it should give us about a 25-mile radius. 4.3. So depending on where you work, it says Elizabethton's here, and it's looking like there's a couple on G Street.
Yeah, but those are not AA programs.
So if you want AA, you just go to AA website to get it, and you put in the zip code there.
Okay.
Alcoholics Anonymous, Narcotics Anonymous, all have their own website, so you can locate.
Yeah, and the NA locator is pretty